I would like to introduce the panel discussants. Dr. Antonio Calles from Gregorio Marañón, Madrid, Oscar Juan from Valencia, Dr. Stephen Liu from Washington, US, and Dr. Natasha Lei from Canada. So we will a shorter discussion. We understand lunchtime is almost there, so I would like, I don't know, anyone in the room? Okay, we have the first question over there.
Hi. So I'm wondering how would you treat an stage 3, let's say an unresectable stage 3, so T3N3 mutant, so EGFR mutant in exon 18 with PDL1 positive?
Sorry.
Yeah, maybe so it's not just for you, but well, whatever.
I think that today, if it's to talk about the consolidation treatment approach for patients with exon 18, I think that the data suggests that afatinib should have a higher response rate. If we want to give osimertinib in this population, as had been presented in the previous session, there is no data, and I think that would not be really the most optimal treatment drug for exon 18. And probably in this population, we can try to give the durvalumab based that there is higher response rate and longer progression-free survival, but the data is really limited. The case would be completely different if it's an exon 21 of this uncommon, but exon 18, I don't have data to support strongly osimertinib that could be the potential standard. But this is only personal opinion. There is no prospective data.
I agree that afatinib has more activity there, but we saw in a study from Jamie Chaff that it's just not feasible, that using afatinib in the adjuvant setting and presumably the consolidation setting is just too toxic.
Any other thoughts?
Would you feel confident giving him a specific scheme or not?
The major issue is that if you think T3N3 is a patient that it has a higher risk of progressive of the disease, and then the sequential approach with durvalumab and probably afatinib might increase the with the second generation, it's lower the risk of pneumonitis. It's depending if you think that you will give osimertinib at that patient, then it's increased risk. If you want to delay the increased risk of this pneumonitis, you can start with the second generation, it's afatinib, and there will not be a lot of risk of this pneumonitis with the sequential approach. So my advice would be probably durvalumab followed by afatinib when progress.
Do you have that the chemotherapy, the combination of chemotherapy have a role in uncommon mutations? Especially because it's easier to combine osimertinib with chemotherapy than afatinib with chemotherapy due to toxicity.
In the adjuvant, you said?
No, in the metastatics.
Yes, it's exactly the same. The major issues depend what uncommon EGFR mutations. Yeah. It's true that if we want to combine afatinib and chemotherapy, I think that the toxicity would be really high. But one other logic approach of intensification apart of lazertinib, amivantamab should be chemotherapy plus osimertinib in this population, specifically for exon 20 and 21. For exon 18, perhaps the lower response rate reported with afatinib could be overcome if we make chemotherapy plus osimertinib even in this population, because the difference in exon 18 between afatinib and osimertinib is a 10% lower response rate of 15 and shorter progression-free survival, but perhaps we can overcome this poor prognostic with osimertinib adding chemotherapy, but I don't know.
Yeah,
how feasible is to make, Jordi, how feasible is to think about, because I'm sure all of us here, when we have these uncommon mutations, we don't know, never know what to do, isn't it? So how feasible is to think about clinical trials? So are we going to have clinical trials specifically for the different subsets, or this is impossible?
I think that it's possible, but first we should try to decide what language do we want to talk. If we classify uncommon exon 18, 19, 20, 21, or we use the PAC classification, the PAC mutation, because otherwise it's really difficult to make indirect comparisons. Because if we want to compare population, okay, the furmonertinib is the unique, at my knowledge, the unique clinical trial that have used PAC mutations as the definition of uncommon, but all the other use include exon 21. So first of all, I think, okay, if we will want to perform clinical trials in uncommon EGFR mutations, we'll use exon or PAC classification. In that way, we can move forward. And I think that it's important to evaluate escalation treatment strategies in this population in all the settings. And also I think it's important in the adjuvant setting because we'll find more and more and more uncommon EGFR mutations because we'll perform next generation sequencing. We'll find more and more uncommon EGFR mutations today. And we'll probably make this kind of alterations with exon 20, 21, we give osimertinib. But if we don't have access because our health authorities do not allow to give osimertinib in uncommon, perhaps we should make a more close follow-up of these patients because have a poorer prognosis. So I think that we should think about clinical trials and also the follow-up of these patients if we have access or not to the TKI in our countries.
I think, Santi, you have a comment to make.
Well, actually, my point was addressing the same issue because I think we have right now more patients having uncommon EGFR and compound mutation that we didn't have 10 years ago. No, in our country, in Spain, that many centers they are using, monogene technique to detect EGFR. I think that we are losing a lot of patients that probably we are not giving the right diagnosis at the very beginning. So I think it's not so easy to do those clinical trials. Probably we have to jump first to better diagnose of those patients. So this is something because we have the experience in the clinic that you have an uncommon mutation and is going for a second opinion and you perform a more sensitive and better approach and you are able to select better the patient. And without talking of the co-mutations because in many centers they are not performing TP53 by routine. So it's quite difficult to address which is the best approach of those patients, no? Because afatinib or osimertinib, but when we are losing half of the information, the biological information of a patient, I think it's really complicated.
Any other? Okay, Delvis, please go ahead.
With HER2 mutation, the patient, unfit patient, not for chemotherapy, in a sense of a randomized clinical trial, of course, do you consider to do trastuzumab deruxtecan in first line?
Actually, this is a very good question, no? Because when you have in phase 1 trial overall response rate, more than 70% of the patient having this, in contrast with having only a third of the patient, I think you can actually have the rationale that this approach is going to be much better than the standard treatment. No? So I think that, yes, it could be an approach. And linking to that and to Noemi, why we are accepting trials to randomize patients for drugs that they have less than or 30% of response rate in the phase 1 trial. With the hyper selection of the patient, only 30% of response rate, we do really think that this strategy, monotherapy, is going to beat the standard of care?
Well, the thing is that what we had was really poor, so that's why they approved mobocertinib, that's why they approved really fast amivantamab. So I guess that depends a lot on the setting you are talking about, and these insertions have really poor outcomes, and you have seen there we have 20 years late. So everything that gives a bit of opportunity, and the overall response rate with early generation TKIs was only 10% and PFS 3 months, so it was really bad. So I guess, but if you look at the data with mobocertinib in the second line, it's very similar of that, the activity of amivantamab in the second line setting. So I think these TKIs, they can have good activity in the first line, or I think they have chances at least to beat what it is chemotherapy. If it's better to combine it with chemotherapy upfront or not, that's another question. I think if you combine the chemotherapy, they might be higher chances to get more difference between the arms. So I'm not sure if this is a strategic opportunity. I'm not sure, but I think, well, I think there might be options that both combined and monotherapy single agent therapies can be a possible alternative or positive trials in the near future.
But I think it's also for HER2, like the Destiny Line 04 trial probably will be positive because they changed the primary endpoint from progression-free survival to overall survival for ensure the market and because the crossover was not allowed.
Yeah.
And we'll have a real problem because the newest standard of care will be the trastuzumab deruxtecan. I hope that will be positive, but all the trials with the TKI are compared with the chemo-IO. I think that also in the same way that we accept, okay, the benefit is the overall survival, but we accept clinical trials that crossover it's not allowed. So then the positive will be a positive clinical trial. It's like the red trial that we know with Libretto. So then we'll have a real problem because how we will decide, okay, ordering that intracranial activity, but these are not the primary endpoint of any of these trials, toxicity profile, but we don't have arguments to say TKI plus chemotherapy or trastuzumab deruxtecan in this patient. So I think that we should try to redefine, but it probably to academic clinical trials, how we'll treat these patients in 2 years, because it will be really difficult.
No.
Okay. Regarding HER2,
Yeah.
I have to ask to Santi about the combination of two mechanisms to blockade the HER2, like ADCs and TKIs, like in other tumor, like in breast cancer. Are there any trials in this direction?
There are some phase 1 trials running, combining everything with everything for HER2. Actually, ADCs plus TKI, as I say, ADC with different mechanisms of action, having 2 payloads, having also an immune modulator. So we have a bunch of phase 1 different trials, but with not anything reported as yet not to present here. But I think toxicity is going to be an issue at that point, and probably we are doing the same, that is mixing what a company has a deal or in the pipeline without really thinking, and this is why I said we have to think about which is the mechanism of action and which patient we are treating. And probably this is why I'm saying that we don't have to accept any trial just because we have a trial, no? Because sometimes it's not making sense for the patients, no? And probably taking the advantage at the very beginning of the trials to really understand what is happening, no? Behind. Not maybe we are going to drop a lot of drugs due to toxicity that maybe can help a proportion of patients.
Yeah, please, you have 2 questions here. Yeah.
We are becoming like victims of our own success. And this is the beautiful of science. Like the science is moving so fast, and the same thing will happen soon with the issue of ROS1. That the comments are coming. You know, you develop one drug, then another one, and we are replacing the previous one just because of PFS or whatever. Okay, and the same thing happened with this issue of the EFR. And I agree with you, Jordi. I agree with you also. I think that we need to do that clinical trial based on the PAC, more structural, more than this definition of uncommon and common that is, you know, from the past when we were doing only FISH or PCR analysis 20 years ago. So I think that we need to go something more biological to explain to that. Because look what happened now, that for many years we use osimertinib for this, quote, sensitive. All of those are sensitive. Even those uncommon are sensitive, but not to certain degrees. Why? Because exactly on your beautiful lecture, how the things happen in the structure of the EFR domain. So I think that we need to develop those clinical trials so we serve our patient better. The issue with osimertinib for so many years, category 1, preferred regimen, and look how just by adding chemotherapy, it seems that chemo plus os is better. And now you have ami, lazertinib, better than osimertinib alone. So I think that we are evolving, and this is because of better drugs, perhaps better design. So I think that we need to rethink how to solve this issue. And not only for EGFR, I think for all these target therapy, all this pathway, because more drugs are coming, and we cannot be replacing one by one.
Yeah.
I fully agree. I think that the way that we have improved the outcome for patients with exon 20 insertion is because we have started to test next generation, to talk the same languages, and then to move forward. So I think that if we start to decide, okay, PAC mutations, then we should make the NGS, then that molecular tumor board identified if it's a PAC or not PAC, because it's not easy, this classification. And then, okay, these patients should be included in a clinical trial with PAC mutations, amivantamab lazertinib versus lazertinib, for example. And then we'll decide if intensification or TKI monotherapy is the standard of care for these patients, and also intracranial activity. It's the only way to decide what to do. Otherwise, every time, yes, every time that we have a patient in the clinic, we should check everything, and it's completely disaster.
Luis, and I think it's going to be the last one question.
The question is about, is there any role in any of these subset of patients to use immunotherapy at any stage at all? And the second question is, on those patients with PAC mutations or HER2 or exon 20 insertions, is there any role in clinical practice, not in research, to do post-progression genomic testing again?
Good question, Wolf. So who wants to start?
For patients with uncommon EGFR mutations, as in my last slide, it's true that there are higher PD-1, higher mutational burden, and when you compare the role of immune checkpoint blockers as monotherapy in commons and uncommons, there are a higher response rate and trend toward benefit in progression-free survival. In the last retrospective analysis with more than 5,000 patients, there was a trend toward longer, but was not statistically significant. So perhaps there is a role, no prospective data. Regarding the genomic profile, as I presented, it's important to know the mechanism of acquired resistance in these patients. And I think it's important that if we have a patient treated with afatinib or osimertinib, it's important to make a genomic profile in the tissue, because there are histological transformation, or in the blood, because you can find a red fusion. Nobody knows if adding selpercatinib in these patients will help. The only data that I found is that patients treated with afatinib that developed the T7 mutations during afatinib were treated with osimertinib and was not able to overcome this mechanism of resistance. But as a principle, I think that if you know the mechanism of acquired resistance at progression, perhaps you can personalize the treatment. Despite the data, it's really
short.
Sorry.
Yes, just to mention that in the Harmony A trial, not only common mutations were allowed, but also uncommon. And there were some responses there also. So limited numbers cannot drive any conclusions, but I think it's interesting to see what happens in the future.
In the HER2 field, actually, I didn't jump into that because it was not the point of the presentation, but we have some publication with CAR-T addressing to HER2 that is very interesting. We have also some specific with ADC and without addressing also HER2. And finally, we have with some other histologies that we have already results, combining immune therapy plus any other strategy, mainly ADCs, that is giving us a good results. So maybe with lung cancer is coming within the next year, combining immune therapy, classical or new models.
So thank you all for being here. Great talks and great discussion, and enjoy the lunch. Dr. Roussel.
Thank you. Wow, nice talk.